Hello and welcome. My name is Jessica Adelman. I work in social media and communications for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Professor Qasim Aziz presenting on gut involvement in EDS. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times. However, you are able to type in questions in the question box at any time. Professor Aziz will not be able to see or respond to any questions until the question and answer time at the end of his presentation. Please do not send your questions more than once, as it will only make it harder for us to sift through them, and it will not increase the chance your question will be answered. This webinar is being recorded and will be posted on our website and YouTube page within the next few days. Professor Aziz is a professor of neurogastroenterology at Barts and the London School of Medicine and Dentistry at Queen Mary University of London. Professor Aziz's research focuses on understanding the neurophysiological basis of human brain-gut connections, and he is currently researching the impact of diet in the EDS population. Professor Aziz has received national and international awards for his research, including the British Society of Gastroenterology Research Gold Medal, and the American Gastroenterology Association Janssen Award for Basic and Clinical Research. Professor Aziz is the Gastrointestinal Working Group Chair on the International Consortium on Ehlers-Danlos and Related Disorders, and a member of the Ehlers-Danlos Society's Medical and Scientific Board. Thank you so much, Professor Aziz, for being here today.
Thank you very much. My pleasure to be here, and to all the attendees, thank you very much for joining me for this webinar today. So I'm going to talk about the gastrointestinal involvement in hypermobile EDS and HSD. And to start off with, just to make you familiar with the gastrointestinal tract, because sometimes when I see my patients, I'm not always entirely familiar as to what the gut actually looks like. So the main thing to say is that it's a long tubular structure, starts at the mouth and just moves down from the pharynx to the esophagus. And at the lower end of the esophagus, there is a valve that allows food to go into the stomach. And the stomach is this sort of globular part of the bowel where all the food is digested and mixed with acid, is churned into smaller pieces, and then sent to the small intestine for digestion. And it is in the small intestine that absorption of nutrients takes place, and whatever is then left, which is not required by the body, goes into the bowel, which is this large or long tube, which is where the waste is. And gradually, as this waste moves along the bowel, the water is absorbed back into the bloodstream, and the solid stool eventually passes out. So this is the basic structure, and I've talked a little bit about the basic functions of these parts of the gut as well. But when and of course, we mustn't forget here that the rectum is a sensory reservoir and stores the stool until we're ready to evacuate. But when we look at the cross-section of the guts, this figure here shows right in the middle is what we call the inside of the gut, or the lumen, and there are a number of projections into this lumen which are called the villi, which help to increase the absorptive surface of the gut so that the nutrients can be absorbed better. And then just underneath this layer is what we call the submucosa. And in the submucosa, there is a layer of nervous system. This ring that you see, the green ring with some maroon dots in it, is the nervous system of the gut called the submucous plexus. And then we have a muscle layer of the gut called the circular muscle layer on the inside, and another muscle layer called the longitudinal muscle layer on the outside. And between this circular muscle and the longitudinal muscle, there is another layer of nerves called the myenteric plexus. And it extends all the way around the gut from your esophagus down to the rectum. So the important thing to remember is that there are muscles there in the gut and there are nerves there in the gut. And this nervous system of the gut is just as extensive as the central nervous system, and it has the same type of nerves within it. And these nerves communicate with one another and with the muscle layers in the same way as it happens in other parts of the body. If we actually then take a further cross-section across this part of the gut, just to look at what is in there in these different layers, we look at this because what we're trying to show here is the muscle on the outside, the longitudinal muscle, and the muscle on the inside is the circular muscle, and in between, as we said, is the nervous plexus. But what you can see is in red, these long tubular structures that are coming down are connective tissue scaffolds. And within that, you have collagen fibers and elastin fibers. The collagen is shown in red, and the elastin is shown in blue. And a lot of these collagen and elastin fibers are around the nervous system of the gut. So not only does the gut have these fibers of collagen, elastin, and various other connective tissue proteins in the muscle layers, even in the submucosal layers, but they're also present around the nervous system. And I think that is quite an important point to remember, because if there is a dysfunction in this collagen, not only will it change the function of the other layers like the muscle layers and so on, but it can also change the function of the nervous system in the gut. And indeed, we know that patients with Ehlers-Danlos syndrome do experience gastrointestinal problems. This is the results of the first study published to demonstrate this by Professor Rodney Graham and Dr. Alan Akin. They did a survey of the patients coming to their clinic, and at that time, this condition was often described as joint hypermobility syndrome, hence the abbreviation that you can see of JHS. And they looked at healthy controls as well. And they looked at the whole range of symptoms that these patients were complaining of, from joint pain to fatigue, anxiety, depression, gastrointestinal problems, but also heart and respiratory problems, migraines, poor sleep, allergies, etc. And in almost all of these domains, the patients report more symptoms than in controls. And certainly if you look at the gut symptoms as well, they complain almost twice as much gut symptoms in comparison to healthy controls. And the reason why people get tummy problems in EDS can be because of three main issues that can develop in the gut. It could just be a mechanical problem, so that because we know it's a tubular structure, the movements of this tube could be somewhat abnormal, and that would cause symptoms. The gut could be more sensitive. We've just seen that there are lots of nerves within the gut, and these gut nerves can become sensitive, just like nerves anywhere else in the body can become sensitive when they are injured or inflamed. And the third reason that I think that patients develop symptoms is because the gut may have become more leaky. We'll explore all of these possibilities in a bit more detail. Let's look at mechanical problems in the gut. First thing to remember is that, as I've shown you in my previous slide, the gut is a long tube, and flow in a tube obeys the basic laws of physics. And so if you look at it from the perspective of the fact that it is a bit like a plumbing job, just like the plumbing under your sink, if you look at it carefully, looks a bit like this. There are lots of pipes that are bringing water to the taps in your kitchen or in your washroom, etc. But you will notice that all of these taps are made of metal and they're not made of rubber, because flow, or the speed of flow, is inversely proportional to the cross-sectional area. So the wider the tube, the slower the flow, and the narrower the tube, the faster the flow. Hence, if you have a more elastic tube which will expand as the water is flowing through it, it will be slower than a tube which is made of metal, which cannot expand. So while the gut is not made of metal, but is not entirely a floppy organ, and therefore if the gut were to become more elastic and stretchy, then the flow in this gut could become a little bit slower than it should be. So that could be one reason. And of course, as you can see, when you open your tap, the water gushes out because of this metal pipe, which is bringing the fluid the water to your tap. But if you have a hose pipe, which is the old-fashioned hose pipe, which is made of rubber, you will actually see that the water flowing is not as fast as the water in your tap coming through those metal pipes. And the main reasons, as I've mentioned, is that there could be a weakness in the muscles or a weakness in the nerves, because there is connective tissue around both the muscles and the nervous system as well. And it is therefore possible and plausible that weakness caused by presence of connective tissue in these parts, or in these layers of the gut, is what is causing the problem. And of course, we have, and others have also explored in much more detail now, in the last 5 years in particular, the association with gut symptoms in patients with joint hypermobility, and compared that with healthy volunteers. And there is general consensus that patients with hypermobile EDS or HSD experience a range of tummy symptoms such as heartburn. They have particularly this is particularly a common problem of fullness after a meal, or bloating after a meal. They can have problems with swallowing, they can have abdominal pain, and they can have abnormal bowel movements, which can range between constipation and diarrhea. And some people move from one to the other. They may have a constipation phase and then go into a diarrhea phase, and vice versa as well. So there's a whole range of upper and lower gut symptoms that our patients can experience. And they appear to have more of these functional gastrointestinal disorders where the cause is not entirely known, such as functional dyspepsia and irritable bowel syndrome. For instance, patients with functional dyspepsia will complain of burning discomfort in the upper part of the tummy, which may grow up in towards the chest, like you would experience acid heartburn. You can get tummy pain and nausea. You can get this feeling of fullness after small meals, and the feeling sometimes is described of a band-like pressure, which doesn't allow them to eat more than a small amount. And bloating is quite often a common feature in this condition. We've already talked about the fact that heartburn and reflux symptoms can occur due to acid or bile coming up into the esophagus. This can cause a burning sensation in the chest, but some patients have more symptoms in the throat, even as the reflux head comes up into the throat and causes burning discomfort, and patients can sometimes wake up with sore throats, etc. in the morning. And other important thing to note is that this reflux in most of the patients does not occur with inflammation. You do an endoscopy, and quite often you don't actually find an inflammation in our patients. They seem to have what is described as non-erosive reflux disease. Erosions or small ulcers can be seen during endoscopy, but in our patients with EDS and reflux, we normally don't see this. So the question is, therefore, what is causing these particular symptoms? So if you look at the peristaltic contractions that occur in the esophagus, for instance, we see that there is this pressure wave that moves down the esophagus as the food bolus is going down from the mouth into the stomach. And this can be studied with the help of a catheter or a tube which has got pressure sensors on it, and you can position the pressure sensors in the esophagus, and you can see here in the upper esophagus you have a band of high pressure, because high pressure is denoted by more tones of red, yellow, and purple, and you can see that there's high pressure zone here, and when you swallow, that pressure band wave sort of gets disrupted, and you get a low pressure area because the valve here opens. And you also see that the valve which is present at the lower end of the esophagus also opens up, and the pressure drops there from this as baseline. And then you see a pressure wave go down the esophagus, taking your food bolus along with it. In a lot of our hypomobile EDS patients and HSD patients, this pressure wave in the esophagus is poor or weak. And that can be a cause for feeling of something stuck in the chest, but also if more acid reflux comes up from the stomach, then it will take longer for the esophagus to clear it by causing movements in the esophagus. So patients are more likely to experience symptoms because of the contact time is increased. In patients with indigestion or dyspepsia, as I just described it, slow emptying of the stomach has been described. So this is what a normal stomach looks like. You have the esophagus come to meet the stomach here, and at this point you have the gastroesophageal junction or the bowel. And the stomach basically is a hollow organ, and if you have had a meal, then the stomach contents will accumulate as such. The duodenum over here is where the small bowel starts, and the food will slowly trickle down from the stomach into the small bowel as the digestion progresses. And any delay in the movement from the stomach into the small bowel can cause a feeling of fullness in the stomach. And if the stomach is more sensitive, because the nerves in the stomach have become more sensitive for one reason or another, then even a small amount of food will trigger symptoms such as pain or a feeling of fullness or nausea. Some of our patients also have hiatus hernias, although the literature on this is somewhat divided. Some research suggests that the hiatus hernias are increased in patients with EDS, and other research suggests that that may not be the case. So what is a hiatus hernia? So it's called a hiatus hernia because the esophagus goes through a hole in the diaphragm to come into the tummy cavity. So the chest cavity and the tummy cavity are separated by a big muscle in between called the diaphragm, which also assists in breathing process. So this esophagus is now coming through a hole or a hiatus down into the tummy cavity, and this is the part of the stomach, and here is the lower esophageal sphincter of the valve. In hiatus hernia, you get some of the stomach slipping into the chest cavity through the diaphragm, through this hiatus. So that's why it's called herniation through the hiatus, and hence a hiatus hernia. As you can see, part of the stomach is now present in the chest cavity. When that happens, you're more likely to get acid reflux. You're more likely sometimes to feel discomfort in the chest if the hernia is really quite big. And sometimes this hernia can get trapped in the chest because of tightness that occurs at the level of this hiatus of the hole in the diaphragm, and that can be an intensely painful condition. A lot of our patients also complain of constipation, and the constipation can be for a variety of reasons. The gut itself overall can be sluggish, particularly the bowel, but also, as you can see, normal anatomy can be disrupted. So if you look at the normal rectum here, and here you've got a small pouch that is formed in the rectum. This is called a rectocele. And you also see sometimes that the rectum can collapse downwards towards the anal canal. And this collapse downwards is called an intussusception, and you can see a little bit of that happening over here, that there is a downward movement and collapse. Sometimes this collapse can be so severe that it comes out as an external prolapse of the rectum as well. And this is what I am trying to show over here, that the rectum, on bearing down, is sort of folding into itself something that is called an intussusception. So here we've actually seen this in another part of the bowel called the small bowel, but the same phenomena can occur in the rectum as well, that it can fold onto itself as it moves as we bear down to try and empty our bowels. Moving on to why patients will often develop symptoms. If you take the fact that the gut is sluggish, it is sensitive, and at the same time, because of sluggishness, there is stagnation. And this stagnation can lead to the development of bacteria. So just like you do not drink water from a pond, because pond water is dirty, it is full of bacteria and other infective agents. In the same way, a gut which is not moving very well or not at all for days on end is going to get quite a lot of unhealthy bacteria growing in it. And these bacteria are very, very important for normal function of the gut, because they interact with the gut immune system, they interact with the gut nervous system, and also with the hormonal systems of the gut. And that can lead to a lot of abnormalities in the communication between the gut and the brain, and hence symptoms can occur. These symptoms can be related to tummy pain, bloating, flatulence, which is a lot of wind, etc. But there can be certain central effects of this, that people feel sluggish, they feel tired, and sometimes they may have some cognitive problems as well. As I mentioned, there can be a lot of fullness, tightness, distension, and flatulence that occurs. Some of you may have heard of POTS, or postural tachycardia syndrome, and that can often be related to gastrointestinal symptoms as well. And here I will try and explain why that might happen. The important thing for you to remember is that there are a lot of blood vessels in the tummy cavity as well. And the gut itself is supplied by branches of the arteries. The main artery is called the aorta, and the superior mesenteric artery, for instance, supplies most of the stomach and the small bowel, and the inferior mesenteric artery supplies the large bowel, etc. And when we eat, there is an increase in blood flow that occurs in the tummy cavity to help digest the food. And because to accommodate for that, the blood vessel size will increase. When that happens in somebody who's already running on a low blood pressure, and suddenly there is a loss of blood volume that has gone into the tummy cavity to help digest the food, that could cause a feeling of lightheadedness, fatigue, drowsiness, and some patients even go to the extent of fainting, nausea, and bloating. So this is, I think, just because the blood vessels because they're also a little bit on the floppy side, they have greater capacity, and there is some pooling of blood that may occur within these blood vessels, and that will help to cause a somewhat reduction in blood pressure and increase in heart rate that can lead to these symptoms. And then some patients with POTS may also get something called dumping syndrome, which basically means that these are the different parts. The upper part of the stomach, for instance, is called the cardia, then you've got the fundus, the body, the pylorus, and these perform specific functions, but the main point is that this pylorus, which is the entry point of the stomach into the small bowel, has a valve there, and normally after we eat, the stomach contents stay there because this valve is closed, and then when this valve opens, and slowly the stomach contents start to move down. And the emptying of the stomach basically occurs gradually, and it is slower for a solid meal. You can see that there's a time lag where nothing happens, and then the solid meal starts to empty from the stomach, and in a couple of hours, most of this food has actually emptied. Whereas liquids would start to empty much more quicker. And in some patients where there is delayed gastric emptying, you will see that these curves will shift to the right, and in some patients who have rapid gastric emptying, these curves will shift more to the left. We've already talked about the fact there are a number of arteries and blood vessels around the gastrointestinal tract. And these blood vessels, they are not just surrounding them, they actually go into the lining of the gut. And they go all the way to the inside of the gut as well. And this can lead to a phenomena which is described as osmosis. And some of you who've done some science in school will remember this in their physics and chemistry lessons, that if you take a beaker and divide that beaker into two sections by putting a semi-permeable membrane or a partially permeable membrane, and you put a strong solution, strong concentration solution in one part of this beaker and a dilute solution in the other part, then through these gaps, the water molecules, they move from low concentration towards high concentration. But these more sort of bigger particles can't really move, but the smaller water molecules. The end result is that you get normalization of concentration on either side of the membrane, because the fluid that has moved leftwards to try and neutralize this high concentration has helped to reduce the concentration of the fluid on the other side. Now, the same thing can happen in the gut as well, that when we eat, particularly if we eat lots of carbohydrates, and if our stomach emptying is very rapid, and we drink a lot of fluid, as it can be seen over here. So if you're eating this type of food, a baguette, and follow that up with something, with a dessert of a cupcake or something like that, and the stomach has dumped down all these high carbs and fluids into the small bowel, then through just the increase in blood flow in combination with the osmosis that will occur will lead to a reduction in blood flowing in your blood vessels in the limbs, and less blood will be going to the heart, and that will cause all these symptoms of dizziness, vertigo, excessive sweating, heart rate will go up, you can get abdominal cramping. Usually these symptoms are self-limiting. They start within 15 to 30 minutes of eating, and then they resolve in 1 to 2 hours afterwards. Late dumping is when you get a sudden increase in blood sugar, and then your secretion of insulin overshoots the amount that is required and causes a drop in your blood sugar. But the symptoms, there is an overlap, but there is a difference as well. Tonsura, I understand, is a Portuguese term which suggests dizziness. So you can get dizziness in both types of dumping, but you get more sort of a hungry feeling and a more sleepy feeling, sometimes leading to unconsciousness as well in late dumping syndrome, which is caused by hypoglycemia, whereas early dumping is caused by increasing capacity of blood vessels in the gut as well as the osmosis. The gut can also be very sensitive, and as we can see that the gut has a lot of nerves, and these nerves can become sensitive if there is some injury or inflammation, and this can happen to the nerves in the gut, or if the sensation or the stimulus is strong enough, you can get a problem of sensitization of nerves in the spinal cord. And because of the overlap with anxiety and stress, etc., of chronic illness in a lot of our patients, therefore, a lot of these symptoms can be sensed or felt more by our subjects. And then there are descending pathways as well, which can inhibit pain signals coming up, which are less active in some of the people that we see. But overall, the nervous system can be more sensitive, and it is worth just mentioning a condition that I'm beginning to see quite a lot in my patient is trapped nerves within this muscle called the rectus muscle, and you can see these nerves coming out of the rectus muscle at regular intervals. On this side, they've cut the muscle to show one of these nerves go down. But these are branches of intercostal nerves, and they're coming from the spine. And you can get these nerves, as they go through the muscle, they go through a fibrous canal, which can get tight, and you can get an entrapment neuropathy. This nerve gets trapped, and that can cause quite a lot of pain, and sometimes burning pain, which can be confusing, especially if you're getting burning in the upper part of the tummy. You may say that this is indigestion, whereas it may all be due to a trapped nerve. And this is something we're beginning to see quite a lot in our patients with EDS. The leaky gut issue is largely related to the fact that normally the gut cells, they form a barrier. They don't allow everything to get through. They only allow things that are necessary for the body to get through. But for whatever reason, due to infection, inflammation, stress, the gut can become more leaky. And when that happens, then this barrier function is disrupted and more particles get through, which activates the immune system, and you can start to get allergies that occur, immune system abnormalities. And even this has been suggested that autoimmune diseases could be linked to a leaky gut as well. And of course, we are learning more and more about mast cell activation disorder, which is caused by release of histamine by the mast cells, and they can have an effect on the entire body, the central nervous system, the peripheral nervous system, but can also be an effect on the gut, that if you have a sudden release of histamine in the gut, it can lead to diarrhea, stomach cramps, mutualism, which is a lot of flatulence and wind that these patients often complain of. In terms of management of symptoms in our patients with Ehlers-Danlos syndrome, I often find it helpful, and the patients find it helpful to know that there is an underlying problem. So for us as doctors, we need to demonstrate empathy, because a lot of our patients have gone through a process where there has been no cause identified for their symptoms, which is quite troubling for them. And just a simple explanation for all the multiple range of symptoms they're experiencing, I find is helpful. And then we need a multidisciplinary approach, which is not always available and sometimes easier said than done, but dietitians, pain management specialists, and colleagues who really have a good understanding of POTS, joint problems, urinary tract problems, is really important, because all other specialists are not always aware of the special issues that are present and prevalent in our patients with EDS. So somebody with experience in these conditions is always helpful and should be involved in a multidisciplinary team. And of course, we do need psychological input, because chronic disease will often lead to a feeling of sometimes depression, sometimes anxiety, etc. But that can happen in any chronic disease. We run some simple tests to exclude chronic organic causes like inflammation in the gut, etc. Blood tests, X-rays, scans can be done. And we have noticed an overlap between EDS and inflammatory bowel disease like ulcerative colitis and Crohn's disease. Celiac disease is something we've been able to investigate quite a lot, because there is an interesting association between hypermobility and EDS, which has just been published in one paper so far, and we're trying to look into that a bit more carefully. Autoimmune connective tissue disorders such as lupus, rheumatoid arthritis can also occur in some of our patients, but the exact incidence of this is not clearly being described. We run some physiology tests on the gut as well. We can look at esophageal pressures and the pH profile, or how much acid is coming up, by doing a motility test of the esophagus called esophageal manometry. We put a tube through the back of the nose down into the esophagus with lots of pressure sensors, and we ask the patient to swallow, and then we can understand whether the gut movements or the esophageal movements are normal or not. And 24-hour pH is to measure acid coming up, and we can leave the tube overnight and see how much acid has come up. We can do tests to check for either delayed gastric emptying or rapid gastric emptying. We can do hydrogen and methane breath tests to see if there's overgrowth of unhealthy bacteria in the small intestine. We can look at colonic transit, and then anorectal physiology to look at whether people are developing rectoceles or they're collapsing their rectum when they actually strain. Dietary modifications can be useful, and lifestyle modifications, just such as that we know in our POTS patient, fluid and salt intake, exercise can all help. And in a lot of patients, food can be a major trigger for symptoms, although there is lack of evidence to support specific dietary modification. And this is something we're working on to develop this evidence. And you may have seen some of the advertisements for the work we're doing currently to generate funds to do a clinical trial of dietary modifications in our Ehlers-Danlos syndrome patients, because anecdotally we have noticed significant improvements in our patients by dietary modification. And it's not just gut symptoms, we have noticed improvements in muscle and joint symptoms as well as POD symptoms and so on. Sometimes taking a dietary history with food diaries can help to identify specific triggers, and that will help to avoid unnecessary dietary restrictions. So the FODMAP diets, these are diets which are high in fermentable carbohydrates, and anecdotally we certainly have found benefit from reducing these fermentable carbohydrates like bread, and there's certain fruits and vegetables that are high in fermentable carbohydrates. Dairy products are high in fermentable carbohydrates. Just reducing these diets, and here's some resources that you can look at to learn more about this particular diet. And there is some suggestion of efficacy of low histamine diet in our patients with mast cell activation disorder. And while some patients will certainly notice an improvement, there is no research-based data at the moment to clearly support their use, but in individual patients may be helpful. Antihistamines and mast cell stabilizers are increasingly being used in people considered to have mast cell activation disorder. In patients with POTS who have early dumping and they have rapid stomach emptying, or they develop hypoglycemia, which is late gastric emptying, then just diet and lifestyle modifications like eating small and frequent meals, opt for low glycemic index foods, foods that are not very high in sugar and processed carbs. Fat and protein intake helps to slow the stomach down, so that can be considered. And avoiding liquids half an hour before and after meals can often also be quite helpful, because the liquids help to wash your carbohydrates down into the small intestine very quickly, and that can cause that sort of osmosis effect and early dumping. I often suggest that our patient may want to lie down for about 30 minutes after a meal, and this can reduce some of the symptoms of palpitations, flushing, and dizziness. And of course, overall, there should be an increase in salt and water intake, but not necessarily while you're eating. Pharmacological therapy has been considered for this problem. Medicines which help to absorb more minerals back into the body and therefore more fluid back into the body will help to improve blood pressure, and fludrocortisone is a commonly used drug for that. Blood medicines that help to constrict the blood vessels, such as midodrine, can be helpful, and hormonal treatment with a medicine called octreotide can help to reduce this pooling of blood in the tummy cavity, and can be effective in our severe patients, but has to be given by an injection 3 times a day, although a long-term injection is now available as well. But still somewhat invasive treatment. Unfortunately, some of our patients go on to enteral, which is feedings, tube feeding through the gut, or parenteral, which is tube feeding directly into the veins. Can be necessary in some patients, but it is worth noting that there is a high failure rate of these treatments. There's a high risk of infections, both in parenteral nutrition and feeding through the gut. And pain is quite often a major limiting factor for people who've had tubes put down into their stomach. I always say before going down this route to consider overlap with POTS, histamine intolerance, abdominal wall pain, and small intestinal bacterial overgrowth, because missing these conditions, which are treatable to some extent, can help to reduce patients going towards intestinal failure. And of course, any psychological issues such as anxiety and depression need to be managed. And one has to say that just like eating disorders can occur in any other condition, eating disorders can occur in patients with Ehlers-Danlos syndrome, especially when they're limited in what they're eating, and sometimes they have atypical eating disorders, but in younger patients, the anorexia, etc., have been documented, and that needs to be recognized early. Patients should avoid strong painkillers like opioids because they affect the gut, they slow the gut down, and constipation will become much more severe. And there is a subgroup of patients in whom opioids will increase pain rather than decrease the pain, and they will develop a condition called narcotic bowel syndrome, which is very, very uncomfortable and painful. In patients who have a very sensitive gut, we tend to use drugs called pain modulators, gabapentin, pregabalin, amitriptyline, SNRIs like duloxetine. So a lot of these medications that are actually used in psychiatry can also be used as pain modulators because they help to dampen the nerves down, particularly the peripheral nerves associated with peripheral sensitization. But these medicines also have an effect on sensitization of spinal nerves as well. But other approaches for psychological distress, such as cognitive behavioral therapy, hypnotherapy, deep breathing, serotonin reuptake inhibitors, etc., can all be considered. And there is a significant overlap with psychological issues. It is important to keep the stool soft, and just taking some prunes or laxatives such as Movicol, Seneca, Dulcolax, and prokinetics such as Resolor is a stimulant for the nervous system, particularly those nerves that secrete serotonin in the gut, and that can help to stimulate the bowel. And in some patients with evacuatory dysfunction, glycerin suppositories or enemas, etc., may be required. Biofeedback in those patients with pelvic floor dysfunction, and sometimes when there is a big prolapse, then surgery is also required. Probiotics or good bacteria are said to be helpful, especially if you've got unhealthy bacteria there because of stagnation. No major research in EDS patients, but certainly in IBS patients, there are studies that show efficacy. And in some patients with significant bacterial overgrowth, antibiotics such as rifaximin are necessary. It is important to keep active, and the final thing to say is that as you appreciate that joint hypermobility or hypermobile EDS, as we now call it, is associated with a range of problems from developmental to coordination, chronic widespread pain, fibromyalgia, chronic fatigue, bladder and tummy problems, and pelvic prolapse, POTS. All of these patients can cause quite a lot of comorbidity, and therefore we need a multidisciplinary team to manage these patients. And in the UK, certainly we need commissioned services to help with them. And with that, I'll end my webinar and my talk. I hope that you enjoyed it. There are a number of people that have worked very closely with me who have helped to develop this whole program of research that we're doing in hypermobile EDS. And people like Asma Fikri, who's my PhD student, but is now a consultant colleague. Lisa Jameson is helping me to develop my ideas and her own ideas about the role of nutrition in hypermobile EDS. And she's done a tremendous amount of work as part of her MSc thesis to think about dietary management and develop a dietary management plan for these patients, which we're hoping to test in the near future. And we're currently fundraising for that, and any help and support that you can provide in that regard would be appreciated. Professor Game, Professor Matthias, Alan Akeem, Vic Gular, any of the colleagues like Adam Farmer, etc., Dr. Kazkaz, Dr. Singh-Ratne, Lara Bloom, as a patient colleague, as well as somebody who understands the whole area of EDS and how to develop research, funding opportunities, etc., have all been very helpful. And I'll just be very happy to take any questions. Thank you.
Thank you so much. We do have some questions. For everyone else, you can keep, it's now time to ask your questions, so go ahead and type some in and we'll get to as many as possible. Our first question is, can patients swing from fast to slow gastric emptying, and how may that be diagnosed?
Can they move from fast to slow? Is that the question?
Swinging from fast to slow gastric emptying.
Yeah. It can happen because in any sort of physiological function of the body, there is variation. I'll give you an example. That people, when they're very acutely stressed, often the stomach emptying will slow down. So your appetite will be affected. You don't want to eat. When stress lifts, you're suddenly able to eat. Exams is an example of that. And there can be certain situations, at times of fear, for instance, that your stomach emptying may be fast. So there are these natural variations that can occur. So for an individual, you may get fluctuations based on a number of environmental influences that are affecting your gut physiology. But you don't see variations between very extreme ends, so not from very fast to very slow. You won't have dumping syndrome one day and gastroparesis the other day. But there are some variations in the middle spectrum where you can have some fluctuations.
What advice do you have for getting the right support and investigations from a local doctor when they don't recognize hypermobile EDS as being the cause of symptoms?
This is a difficult one and a universal problem. And I think the only thing I can suggest is that you try and find physicians, doctors who are more understanding of this condition, and if that is not possible because of logistical reasons, then through the support and help of EDS UK or EDS Society, you can provide the material that is available about the link between a particular type of problem and EDS to your doctors and enter into a discussion with them. But this problem also highlights the importance of doing more and more research, because it's very well for us to recognize and understand that there is a link between EDS and tummy symptoms and bladder symptoms and POTS. And until we do the research to convince all our colleagues that this is the case, we are not going to win. And that, and for that reason, it is critically important that more research is done, so that the evidence is created and that evidence is published, so that people can read it and follow the evidence that has been put before them. So from the gut point of view, certainly there is now a lot of papers that are published which explain the association between gut symptoms and EDS. What is lacking is studies at the moment which look at causation. Does one cause one thing being associated with another is useful, information is interesting, but doesn't suggest that there is a causative relationship. And we're currently doing some studies on specific connective tissue proteins to see if they are not present in the gut, what happens to gut function. And we've just had a paper published, accepted in the Journal of Physiology on that particular subject, which is related to lack of tenascin X in the body and what effects that can have on the gut. So it is research like this and in other areas which will then support the cause idea.
Is it okay to use Miralax long term?
Yes. The problem here is that if you don't use it, if you don't use laxative, I get asked this question quite a lot, that is there a problem in using laxatives long term? Will the gut become too sluggish, and so on? It's not that the gut becomes sluggish, it's the fact that these medicines lose effect after a little while, because the receptors that are used to recognize these drugs and implement their action, they get a bit fatigued and you lose effect. It's quite often that if you stop that drug and use another drug for a while and come back to the original one, then it'll be effective once again. If you don't use medicines to empty your bowels and to evacuate, then the other problems of bacterial overgrowth, through that bacterial overgrowth, effect on the gut immune system, so effect on the gut immune system, activation of mast cells, the gut being leaky, those sorts of issues theoretically can occur, and I again emphasize that the research there is lacking. But certainly I tend to see this clinically, that the longer you remain constipated, the more problems that can occur in our patients. So I feel that it is important to treat constipation very proactively, and I do not feel that there is an issue of the gut long-term becoming more sluggish. The drugs can lose effect, but they can be substituted with other medicines.
Are there any special considerations for people who need a sigmoid or colonoscopy? This particular person had an issue where they cannot progress the probe further and needed to try to push past it. Is that okay, or could that cause further problems?
Sorry, I'm not sure I completely understand your question. Is it appropriate for somebody to have a repeat colonoscopy, did you say?
Any special considerations for people with EDS and colonoscopies, and if there's a problem where they cannot progress the probe?
Oh, yes. Okay. So we haven't come across any literature which suggests that increased risk of colonoscopy in hypermobile EDS or HSD patients. However, in patients with classical forms or vascular forms, the risk of perforation of the bowel is there, but not in the hypermobile form. We haven't come across any literature, and there is some work that is going on in Maastricht at the moment, which also seems to suggest that it is safe to do colonoscopy. However, in some patients, the colonoscopy can be quite difficult to do because technically it's difficult because the bowel loops quite a lot. There you really need an expert colonoscopist who has a lot of experience, who usually can get through it. And if even that is not possible and one or two attempts have been made and they've been unsuccessful, then there is another way to look at the colon quite carefully, which is through CT colography. So through a CT scan, you can do a virtual colonoscopy these days. And therefore, you should speak to your gastroenterologists, your doctors, to discuss with them the possibility of doing a CT virtual colonoscopy.
Do you have any advice on selecting the right probiotics?
Not really. There isn't strong enough evidence to recommend one or the other. There are currently 3 antibiotics in the European market where some evidence is emerging about their efficacy in irritable bowel syndrome. There's recently at the British Society of Gastroenterology a positive paper was just presented on the efficacy of a probiotic called BioCult in EDS. There is some reasonable information about the use of Simprove in irritable bowel syndrome, and more recently there is a new probiotic on the market called Alflorex. All 3 have reasonable data, but against quite a few of the others, we don't have any specific data. But that's not to say that they don't work, it's just that we don't have any data to help them support their use.
Can a leaky gut actually be healed, or is that just something that's going to happen with EDS?
Well, I believe that leaky gut can improve, but it takes time, and it takes a bit of effort to try and improve your gut health. As your gut health overall improves over time by using the right nutrition, not allowing the bacterial overgrowth to occur, managing constipation really well, eating very well, reducing some of these fermentable carbohydrates in your diet, which can cause bacterial overgrowth and so on. Over a period of time, the leakiness of the gut can heal. It's not a one-directional effect that once you have a leaky gut, then always you may have a tendency towards a leaky gut, and that may come back. But there is every reason to believe that the leakiness overall can improve.
What could explain a patient having both dumping symptoms and gastroparesis symptoms at different times? Could diet or allergy upset this balance?
So as I said, that there are 2 mechanisms by which you can get symptoms in pods. If you have gastroparesis, you're unlikely to be getting dumping. They're sort of mutually exclusive. unless that the delay in gastric emptying is specifically only to solids and not to liquids, which is a very uncommon phenomenon. Normally it's to both. But you can still get symptoms because of changes in blood flow that occur in the gut. So the increase in circulation in the gut blood vessels and stagnation of blood over there for longer than it should stay there and so on can also potentially again provoke symptoms. But in someone with significant gastroparesis, it is unlikely that they have got dumping as well. And to look into that a little bit more systematically, it is worthwhile to get your blood pressure and pulse as well as your blood glucose monitored after a meal to see whether you're actually seeing any fluctuations in that. You can have this monitored during a gastric emptying study as well, that you can actually see whether the rate of gastric emptying has anything to do with changes in your blood pressure, heart rate, blood sugar, etc. So these tests can be done in specialized centers, and you can certainly have a think and discussion about that.
What does high pressure and an esophageal manometry signify?
It may signify nothing. There are lots of people with high pressures who have no symptoms. But high pressure, very high pressure, especially in the presence of a non-relaxing lower esophageal sphincter, can suggest a motility disorder and can be a cause of chest pain in some patients. So it is not necessary that only presence of high pressure is a disease in itself. Certainly we have seen it in healthy normal people as well. But in some conditions, high pressure in condition has been described as jackhammer esophagus, nutcracker esophagus, where high pressures can be associated with chest pain and dyspnea.
How frequent are large esophageal diverticulum in EDS patients? And if a large esophageal requires surgery, what are your thoughts on the types of surgery, robotic or open thoracotomy?
I'm not a surgeon, so I'm not going to comment on the type of surgery, but it's not a very common problem. I see a lot of EDS patients, and I've perhaps seen just 2 or 3 large diverticuli EDS patients over the many years that I've been looking after my EDS patients. So it's not necessarily in my experience, a big issue. But if it is there and it is causing symptoms due to entrapment of food, etc., which can sometimes lead to infections and so on, then yes, it does need to be managed, and you need to discuss that with your local GI surgeons. I'm not aware of any data to suggest whether one type of surgery is better than the other, but these days most operations are occurring through the laparoscopic route, and most surgery is safe as long as the person doing the operation has adequate experience.
Can you please share more insight on EOE in EDS patients?
Yes, some of our EDS patients appear to have EOE confirmed on biopsy. There is only one paper overall which suggests that hereditary disorders of connective tissue, like EDS, can be associated with a higher incidence of eosinophilic esophagitis. However, that was a case series. So again, a lot more research needs to be done to look at this association. But when it is being diagnosed, there's lots of people who get EOE without an overlap with EDS. When it does get diagnosed, then it needs to be treated adequately. And there is literature to suggest that there is a role for diet, because dietary intolerances and food allergies can be associated with EOE. And there is a role for inhaled steroids and a range of other. When I say inhaled steroids, I mean that the steroid inhalers that are then used but swallowed. The spray is then done into the mouth, but instead of inhaling it, you swallow it, and it goes into your esophagus. Oral steroids have been used, Montelukast has been used. So a range of medicines that can be used depending on the severity of the problem, but it should all be done with the assistance of a good gastroenterologist. It's a common problem, so most gastroenterologists know about this.
Well, it is now the end of the hour, so that is all the time we have. Thank you so much for everything. I will say that a lot of the comments that came in were not questions. They were just thanking you for your presentation and for everything you have taught us today. So thank you so much, Professor Aziz, for being here.
Thank you very much. Thank you. Okay. Bye-bye.
To remind you all, if you missed any part of this webinar, it will be available on our website and our YouTube page within the next week. Thank you all, and have a great day.
Okay, thank you very much. Thank you. Bye-bye.